Good. All right. So just to give you kind of just a really brief background of myself, I've worked with children and families for the past 25 plus years, a long time. And I've worked on a continuum essentially from uh, preventive care all the way to inpatient psychiatric care. A good portion of my time was spent in community mental health. So I have a passion for that work. And I specialize in trauma and working with kiddos who've experienced trauma. I also am interested in kiddos who are diagnosed with autism and looking at kind of when we see like an autism diagnosis and looking at ADHD, we sometimes get kind of the overlap in a diagnosis, and we have to really kind of tease that out to see what that's really about, as well as reactive attachment disorder. So those are kind of my areas of interest. So you have some background there. And my last position, I worked with the Palm Beach County School District, and we started a program in a Title I elementary school that served mostly, probably about 85 to 90% were undocumented immigrants. And we started a program there to provide wraparound services within the school because it was very difficult for kiddos to get out to get services without insurance, without social security number, right? Without transportation. So I brought social work interns into the school so we could provide those services in-house. And that's been running for about 7 years, and it's still going. So I'm very happy. It was very hard to leave that, but I'm very happy to be in Morgantown. So all right, so let me see. I'm going to share my screen and hope this works. If I can find it, there we go. Nope, you don't want my calendar. That's the screen. Okay, hold on here. Why am I not seeing it? Just a sec here. Okay, it's not going to do it. Okay. And if not, if I can't share my screen. Oh, no, I see it. There we go. Okay, so sorry. All right. So let me put this on. I don't want you to see this view. I need the, I can't see that. Hold on, guys. So sorry. Technical difficulties all the time. Okay. Slideshow. There we go. Okay. All right. There we go.
That looks perfect. Thank you.
You're welcome. And I want to thank Amanda Newhouse because this is mostly her PowerPoint. I just tweaked it a little bit to add some different things. So thank her very, very, very much for this. And we will move forward. So this is, I'm going to move pictures of people. There we go. Behavioral health and mental health treatment with children. That is, like I shared before, my area of interest. I know, oops, didn't mean to go forward, but here we go. All right, so as you see from the screen share, that 1 in 6 children aged 2 to 8 years of age has a mental, behavioral, or developmental disorder. And we're seeing so much more in the increase in the last few years since COVID. It can be in part because of COVID and all of the isolation. But also I think something positive that came out of COVID was the telehealth, right? And the access to mental health care and more discussion of anxiety, depression, so that kiddos had an opportunity to really to share these feelings. So that may be one reason that we're seeing, more of this. And looking at behavioral and developmental disorders, I think it's really important to really give some time to observe and monitor the behaviors of children to determine if this is truly a mental health issue, is it strictly behavioral, or do we have something else going on, right, that we may need to address in PT, OT, speech, all of these areas to help that kiddo really meet their developmental milestones, so then they are able to express, use their expressive language in a helpful way. And please pop in with any questions or any comments or anything. I like this to be, informal. So as we see, we saw a 24% increase from April to October 2020, 2020, and that's with everything with COVID. And I know in my practice now, most kiddos, and particularly adolescents, are presenting with anxiety and depression. Okay, so this gives just a breakdown, right, of ages and kind of the spike in the different types of disorders. And I know probably everyone is seeing this in their own work. If you work with children, or if you work with parents, if you work with adults and they may be discussing their children. So we're all, seeing this more and more in our daily practice. Okay, this is supposed to be a video, so let's hope this works. There we go. Okay. So this is the idea of, toxic stress and the impact that toxic stress can have on a child's development. And for even those folks who work with adults and don't work with children, I know when I teach about this in classes for social work students, we talk about the importance of doing that full assessment with adults. So understanding what may have happened, right, in their own development, what they've been exposed to, if they have any unresolved trauma. So even though this is focused on children, this information is very helpful when working with adults and using a trauma-informed approach to really kind of tease out if they have a history of trauma or adverse childhood experiences. So this is just a really quick video on toxic stress. It's through the Harvard University, the Center for the Developing Child. So I'm just going to play this quickly. Can you hear it? Can you hear it or no?
Sounds a little quiet. Can anyone else hear it?
Let me see.
Learning to deal with stress is an important part.
Yes, we can hear it. Awesome.
Experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
Okay, so this gives us an idea of what toxic stress is. And for many of the children and adults that we work with have been exposed to some sort of toxic stress. Now, we do have a resiliency factor in place if that individual has, some protective factors, like one person, even a teacher, someone at church, whomever, that they may feel particularly close to, that they feel like that person is looking out for them and helping them. So there is that resiliency factor with that. Now, stress as it stands can be a very positive emotion, right? Because stress can make us, if we're in danger, it can make us, make a decision to fight or to flee, right? So some stress is okay. I have to study for my test at school and I'm stressed about that, but it's a more of a positive stress, right? But if it continues, like with toxic stress, that exposure, that, the issues of poverty, right? Issues of domestic violence, of abuse, if we have, physical abuse, emotional abuse, or sexual abuse. If there's not a response in the community or the school for that child, a positive place for them to be, right? This just increases that reaction to toxic stress, and then you can't extinguish that fear response. So this leads to dysregulation in children, right? And we see this as, they get agitated, they get aggressive, they yell, they scream, they can tantrum for 10 minutes, like the 3-year-old who was in my office. And it can lead to more significant mood disturbance if not addressed. And in teens, we see this as that it can lead to depression and suicidal ideation, right? And aggression. And we've seen such an uptick in SI, suicidal ideation, also, non-suicidal self-injurious behavior, depression, isolation. So that's a response to the toxic stress, the toxic stress exposure. Any questions as I'm going? I don't, just talking to myself here. So the body responds, and I wanted to show this quick little video because this is very helpful to explain what's happening in the brain in a very basic way that children, even as young as 5, can understand. Because we can use all these big words with kiddos, but they're not going to understand it. They need something that's tangible, that they can see, that they can understand. So this is Dan Siegel with the hand model for how you flip your lid, right? As he's discussing the amygdala, the reaction, and the executive functioning, and how everything is impacted. So it's really a nice little video. And again, it's an easy way to explain it to kids, but also adults, right? Because so many adults have difficulty regulating because of a trauma background that was never addressed. So I'll show this real quick.
One of the most rewarding experiences for me has been to study brain science and apply it to the experience of parenting. And the hand model of the brain that I use to teach parents is very useful to understand that. So if you take your thumb and put it in the middle of your palm, put your fingers over the top, this is a very useful model of the brain. And when we can actually see in front of us what's going on in the brain, then we can change what the brain does. So let me walk you through very basically what happens in this brain and the structures in it. And it goes like this. The spinal cord comes up, representing the wrist, and then you have coming up into the skull, the brain stem and the limbic area, which work together to help regulate arousal and your emotions and the way you have a fight, flight, freeze response. These are below the cortex, the limbic and brainstem areas, and the cortex is this higher part of the brain that allows us to perceive the outside world, to think and reason. And this frontmost part of the brain, right behind your forehead, so the person's oriented like this, is actually the part that regulates the subcortical, limbic, and brainstem areas. This regulation is very important because sometimes we can have all sorts of things happen in our life. We're tired, we're exhausted, someone pushes a particular emotional button, and we can flip our lids. So rather than being tuned in and connected and balanced and flexible, we can lose all that flexibility, even lose moral reasoning, and act in ways that are terrifying to others, including our children. Now, you can actually bring yourself back online and come back to the high road and make a repair with your child. And that's important to explain to them. And you can also use this hand model of the brain to explain to children, even as young as 5 and 6, how to understand when their emotions are rising up from the brainstem and limbic areas here, and how it's overriding the prefrontal area and making it so they may be about to flip their lids. So I've had kids come tell me that they're about to go flip their lids and they need a break. They need a timeout. And by even just naming that, they can tame it. And that's the power of using the hand model for ourselves and our children to help us all make sense of what goes on in the emotional communication that we have in the course of day-to-day life. One of the most
Oops, sorry.
rewarding
He wants to say it
experience.
again. So this is so incredible. I think it's a very basic intervention to use with children and adults, because kids who have been exposed to toxic stress and have the chronic stress throughout their life, right? They are responding to that amygdala, right? They're responding to the limbic part of the brain here. And this is where they're deciding if they're going to fight, if they're going to flee, right? If they're going to freeze. And in the next slide, you'll see that also if they're going to try pleasing behaviors, to try to protect themselves. So that's kind of a new addition to the fight, flight, and freeze is please, right? So this helps them to understand that if they can get control, right, of this emotion, if they can calm their bodies down, then they can make a better decision when their lid is not flipped. And they can make better choices, but that's takes a lot of practice. It takes work, it takes understanding, it takes the caregivers in their lives to have an understanding of that as well. So really working with both the child and the caregiver on how that child can self-calm. And also, hoping the caregiver can do that as well. Because unfortunately, if that child continues to live right in that amygdala, this is what we see happening at schools, that we have behavioral issues, we have impulsivity, we have a lot of different manifestations of behaviors that look like maybe an ADHD, but it's a trauma or toxic stress response. So I just love that model, and I think it's really great to use with kiddos and adults. Because kids, as you see on the slide, that they've been exposed to toxic stress, have extreme emotions, have very difficult time regulating their emotions. They can be hyperactive, and you can see a lot of mood shifts, right? Because they're responding to that basic instinct of fight, flight, freeze, or please. And with teens, we can still see a lot of that behavior. But that with teens, we see a lot of sleep issues, right? And that sleep hygiene, that's so important. They're not getting enough sleep. We see memory loss associated with that because they can't really focus on what's in front of them. And so they can't remember what's going on. Difficulty concentrating as well, because if you're living, you're in the thumb part, right? If you're living there, you're not able to concentrate and to be calm and focus. So that's why so many of these kiddos we see have difficulty in schools. And schools, I think, are beginning to adapt, but they're still a little bit behind in that. So like I said, the fight, flight, or freeze, and please. I have an example. I have a kiddo who visits with her father, right? And dad is a yeller and he's scary. So she's very yes and pleasing, and because she's trying to protect herself, right? And with the mom that she is more connected with and doesn't have that fear response with her, she acts out a little bit more, right? But you can see in that example that she's really trying to please the dad, and because she does not want to be in an unsafe situation. So instead of fighting with him or just freezing or running, she tries to please. So that's something new that's being kind of labeled with that response. There we go. All right. So when children experience kind of the chronic stress or toxic stress, you see the dysregulation, you see behavioral concerns. This is when we get the calls from school. You can't see developmental delays because depending on what the type of stress is, if the parent isn't able to attune to the child's developmental needs and to encourage that, and encourage reading, and encourage physical activity, to encourage gross and fine motor development, you see those delays happening, right? And what we see so much and get so many referrals for is the impulse control. And in adolescence, like we said earlier, you see more depression, risk-taking behaviors, thrill-seeking, with experimenting with different substances. We see that. We see the non-suicidal self-injurious behavior, and more impulse issues with kiddos who have experienced, that exposure. And then just to continue with that, teens are very good at avoiding activities, kind of staying in the room if that's what their mode is, that they just isolate. We are seeing an increase in, the anxiety and mood disorders, and some, the physical symptoms, self-esteem, not being able to get along with peers, and like I said before, the self-harming behaviors. So this is all a result of that exposure and the lack of intervention to help those kiddos to really understand that things can be different for them. So how to build resiliency, right, in adolescence. With parenting, you want to give choices so they feel like they have some control over decision making. Positive role models. If we could have so many more mentoring programs across the United States, that would just be absolutely incredible, because that's really what is needed. And if it's to a certain point, obviously getting, the help through a therapist or psychiatrist, psychologist, and then developing those coping strategies to manage emotions. And that's what we work with kiddos from, age 3 and up, is that foundational skill or skill set to help regulate their emotions, giving them those mindful breathing strategies so that they can self-calm, teaching them how to orient themselves and where they are, teaching them how to be more tolerant of situations around them. And then also with that, you're working with the parent or caregiver to help them understand how they can support that child in doing that. So providing treatment with children and adolescents. We use cognitive behavioral therapy, which I think most folks have heard of, at least, or are familiar with. And it's helping that child kind of reframe that thought process, right? And that response to that thought and the emotion connected to it and the behavior that comes from that. Dialectical behavior therapy is really, I'm not trained in it specifically, I'm not certified in it, but I have been dabbling in it, and I really like it because the essence is for mindful, right? Mindful strategies to be in the present, right? So yes, a lot of stuff has happened, but let's focus on what's happening now, how we can learn to control that, and then how we can move forward from that. And I really like with dialectical behavior therapy, they work on, increasing that window, making that window of tolerance bigger, so you can really tolerate, some negative things happening, but you have the strategies to calm yourself and to problem solve and to move forward. And then group therapy is always a great mode of intervention, because kids will learn from each other and they are very honest with each other. So it can be just a very positive experience. Motivational interviewing, behavior modification more so, I think, with the younger kiddos or kids that we see with autism or ADHD, it's particularly helpful. Play therapy, which I'm a huge fan of, if you can't tell from my office, that play is a child's language, and that's how you will get them to understand these skills. I know when people see play therapists, they think, oh, they're just playing with those kiddos. How hard is that? But it's really a way to kind of go in through the back door, essentially, and try to really get them to understand in a language that they know, which is play. Oh, I have group therapy twice, sorry. All right. Okay, so challenges in the system. I know I'm more familiar with my recent experience in Florida, and so becoming more familiar here with some of the issues. Also, as always with most places, is access, right? Having transportation, a way to get to an appointment, and having folks knowledgeable of resources in the community. So for example, I learned yesterday about a Medicaid transport system that can bring patients in for services. So it's becoming familiarizing yourself with all of the resources and what is possible. And now with telehealth, it just helps so much, particularly in this state is so big. right? And we have, limited providers. So telehealth is very, that's a great move, although it's something I'm becoming more familiar with, but it was a hard change for me. And we have to look at the living conditions, right? In the school system, we do have the McKinney-Vento program. It's a federal law, federal legislation that provides additional resources for students who are homeless. And with the definition of homeless for the school system, it's a little different. You can have shared housing, right, is considered homeless. And I know where I worked in Florida, we had so many families who were sharing housing because they would come from, Central America, and they would stay with families, and you could have 18 people in a 2-bedroom apartment. So, and just helping them cope and deal with that situation, right? So yeah, and then we see our kiddos who have had multiple caregivers. Maybe they're in foster care, and maybe they've been in relative care, but they've moved several times, and how that is disruptive, right? And then the issue of confidentiality, right? Making sure that we're being cognizant of that we're keeping their information private in a very, technological, tech savvy world. So, all right. So treatment services to increase compliance, right? I think I'm just very passionate about school-based services, just because we have the kiddos there for 7 hours a day. They're there, and we don't have to bring them in. We don't have to worry about transportation, and we can provide services in the school, providing those counseling services, the group therapy, right? Case management services to link them to resources. So I am just really, and I realize I'm out of time, or almost out of time. So it's really, I just feel very strongly about this, and I think that needs to be a focus of most clinical services, is to find a pathway to build that connection with the school and to be in the school system. And mental health and behavioral health into pediatric primary clinics. We had this in Florida, where it was through the healthcare district of Palm Beach County, and they did have therapists at the health department who could work with children and families, but unfortunately, like, their service was a brief service, so it wasn't something that could continue for very long. But then they would work to try to connect the client to services in the community. Increasing, like I was saying earlier, just being aware of the services that are in your community, and to give access to those services to the clients that you work with. And sometimes they may need help, picking that phone up and making that call. You don't want to do it for them, obviously, but you want to be a guide and help them to do that and support them in taking that first step. And then, time myself. And then the crisis centers, right? That we have, and I do believe we have that here in Morgantown. Not familiar with other places yet, but having that mobile crisis, that mobile response team, if there is something happening, if a child is suicidal, and a family doesn't know what to do, and having that mobile response team. I know we had 2 in Palm Beach County, and sometimes it would take a bit for them to get there, but they would eventually get there and then be able to assess and then provide services. And stabilizing services, if we have kiddos who are in inpatient care, making sure that we connect to the appropriate step down, right? So outpatient therapy or intensive outpatient therapy and case management services, and then following through with that. Okay, questions, comments? I'll stop sharing.
First and foremost, thank you so much, Kelly. That was a wonderful presentation, and I just want to give you a big shout out for your first ECHO presentation.
Thanks.
Yeah, so much wonderful information in there, and anyone with comments, questions, you're more than welcome to unmute and chime in, or if you prefer to chat in, I'm happy to read that as well. So we'll do what we call an echo pause and not until like 10, until some folks have time to soak it all in and have a moment to ask a question. No pressure.
Actually, actually, I have a question. If that's okay.
Absolutely.
With the CED program, would somebody be willing to tell me a little bit more about that program?
Yeah, Heather, I saw you unmute for a second there and invitation as well. I don't want to call anyone out.
It's like, yeah, the involuntary here. I actually came up with a question, but I'm more than happy to share. And of course, anyone else from the team, please jump in too, if I leave anything out. But we are at the Center for Excellence in Disabilities in Morgantown, but we have staff, all over for different programs. Our particular program is positive behavior support. And so we provide information and trainings for providers statewide. And then we also provide client services. So we have 3 different levels somewhat of services. We have intensive, which is like a short-term intensive program to provide gap in between services for clients. We do brainstorming sessions, which is like a resource meeting where we meet with a team. We get as many of our specialists and other therapeutic team members for the clients on the call and gather as much information as we can for them, which is extremely helpful for the clients that are in very remote rural areas and are unsure and unfamiliar about the program or about the programs that are out there and exist for them. And then we do person-centered planning, and so we do, that's like using a map or a path or different tools. And right now we've been collaborating with the Country Roads program, which I don't know if you're familiar with that, but it's really cool. It's like a program for college students here at the university. And we go in and help them with those tools, plan for their, first year of school. So hopefully I covered all of that. Nick, feel free to chime in, or anybody else if I had left anything out. But I do have a question, and this is coming up a lot in the conversations we're having here. And I see it all the time, and it's kind of making me a little like crazy. The younger and younger children are getting diagnosed with oppositional defiant disorder. And then I see, on their, notes that they have this, provisional autism spectrum disorder, or they already have that diagnosis, and then they have ADHD, and there's like this long string of letters. And I can't help but think, if we start with just the spectrum diagnosis, wouldn't a lot of these things that are symptomatic of the other disorders really be symptomatic of autism? Maybe it's not truly oppositional defiance, and maybe it's something within that disorder and there's symptoms for that. Like, coming from Florida, did you see the same thing? Because we see it all the time in our intake process.
Yes, and I have, well, I won't get on my soapbox, but with oppositional defiant disorder, I do see that diagnosed a lot. And I think that it's oftentimes misdiagnosed. And I think just from my clinical perspective, a lot of times we have kiddos presenting with very oppositional behaviors, but they also have may have a trauma history that has never been investigated, has never been they haven't been assessed for that. They haven't had any intervention for that. And I know working in the school district, that's what I would see all the time. And these kids would get to the highest level of intervention and then have to, have an IEP because of behaviors. And they present with years of trauma that was never addressed. And it's like, okay, let's go back to that. Let's start with that. So I think it's critical to assess for that when they're little. I don't see how an oppositional defiant disorder really helps us, in determining services for a kiddo. You were speaking of autism. I think a lot of times too, that can be certain, obviously symptoms are attributed to autism, but I think, and we've seen such an increase in the number of kiddos with autism, but I think, and this will respond to Dr. Swager's comment about reactive attachment disorder. That's also on a continuum, right? And I think a lot of folks are very hesitant to diagnose with that. And we see it so much, particularly with kids in foster or kids who've been, switched around to different caregivers. And I think that's something that we need to thoroughly assess for as well. But I agree completely. Let's kind of just take the diagnosis off for a second and look at what strategies would be most beneficial for that child, right? We look at some behavioral interventions to help the parent or caregiver. We look at helping that child learn the emotional regulation skills that they need to have. So I think just kind of putting that aside, provide the direct service, and then see the response. And that kind of gives us an answer too, right? Because if you have a kiddo who's still really impulsive after all that work, then you really might be looking at ADHD, right? So I think giving that, particularly the early intervention, and I know Amanda will agree with me on this one, getting in there early and really addressing those core issues that are presenting before we jump to a diagnosis, right? And I know in the state here, I think the developmental delay diagnosis in the school district can now be up to age 7. In Florida, it was up to age 9. They just changed it, which was really great, because prior to that, you could only have that eligibility in school until you were 6. And then you had to have a diagnosis or you would have no services. So this does give us a little bit more time to see what's really happening there. And just very briefly, I'm sorry, I don't know, do we have our presenter here for the case?
Yes, we
Yeah,
have
okay.
no worries at all.
Thank you, Kelly.
Yeah,
That was
you're
great.
welcome.
Thank you.
Yeah, and just really quick, just because I've seen this so much in the last couple of years, when you have kiddos who have no exposure to outside of their home, they can really present like a kid who may have autism, because they just, and I had a particular student when she was in kinder, we really thought, okay, we're looking at, a possible diagnosis of autism. But as she got, into school, because it was her first exposure to school, then we saw her slowly develop skills that she needed for positive peer interactions, for engaging with her teachers. So sometimes it is just a lack of exposure, right? So yes. Okay, thanks.
Thank you so much for that question, Heather, and also for explaining the program, and Kelly for answering that question. Any other comments or questions from the group? Dr. Swagger put in some great comments as well in the chat, so definitely take a look at those. I'll give it an echo pause here. Don't want to rush anyone, so feel free to ask away if there are more questions.
I'm just going to make a comment. I think I totally agree with Kelly and Dr. Swagger. It makes me think of just this week I had a student want to diagnose a 3-year-old with ODD, and I was like, well, let's look at this, right? And so really just, I think a lot of the times, like Dr. Swagger said, a lot of the behavioral health people, we steer away from that because we see, like Kelly was saying, the complexity. And I think the other piece is understanding development and how oppositional is so natural within development, and looking at the dynamics within that and the system, I think is important too, because if you look at the criteria for oppositional defiant disorder, almost every kid under 5 will meet the criteria for it. So I think it's so easy for people who don't really understand looking at those other issues that impact those behaviors to say, yep, this is where it plugs in. And so I think like they both were saying, I just concur with them both on what they're saying about exploring that and other avenues.
Thank you so much, Amanda. Any other comments, questions from the group? Alrighty, well, thank you again, Kelly, for that presentation and for answering all the questions, and for you all being on here as well. But we'll transition over to the case portion. Thank you so much, Tracy, for hopping on. I'll screen share and pull up your case for you, but anytime you'd like me to go up or down, scroll up or down, just let me know and I'll make sure to do that. But is everyone able to see that okay? Getting some heads nodding. Awesome. All right, Tracy, I'll turn it over to you.
Okay, I apologize. I was having some technical issues trying to get in. So if my face popped up and then out and up and out, that was what was going on. Okay, so this is a young lady who just moved to our area probably, I think it may be 2 months ago. I think this was our second visit. As you see, she told me she had a history of being diagnosed with bipolar, anxiety, and possible ADD, but her previous provider wasn't sure about the accuracy of the diagnosis. Her depression dated back to 2017, and it started as postpartum depression following the birth of her first child. And following the birth of her second child, she resumed the medications that she had previously been on, and they did not work as well. I think that was Trintellix and oh, lost where that was. Well, it's in here somewhere. So she came to me, and at that point, she had been on Latuda, guanfacine, and Prestige. She stopped all those medications prior to coming to our visit because she assumed that I would try something different. Okay, under medicines, that's where that was. Between her after her second birth, between birth 1 and 2, she did Trintellix and Rexulti with her other provider, but after the second pregnancy, it did not work. You can see the other medications that she had tried: Trazodone, Vistaril, Seroquel for sleep, Zoloft, quote, made her mean. Wellbutrin wasn't effective. Buspar has been effective, and she's been on Ambien 5 milligrams for several months. So at the visit, she had been off all her medicines. We started Caplyta. She didn't come back for, it says 8 to 9 weeks. I think it might have been a little longer, but she had had a good 3 months of trying Caplyta. Her depression screen was still pretty high, but what she told me, she said, I have no joy in anything. I just have no desire to do anything, and I just have no joy. And she'd asked back about her previous possible diagnosis of ADD, and mentioning that she gets overstimulated. And then she says, I look at my house, I know I need to get started cleaning. I just don't know where to start. But once I get started, I'm okay. So question really was, mostly she complains of just not having any happiness on doing anything, and lack of motivation. And the Caplyta didn't seem to be very beneficial.
Thank you so much, Tracy. Another great case presentation. We appreciate you bringing these cases to the Psych Echo, but I'm happy to pull up the case again if anyone needs to refer back to it. But before any recommendations, any clarifying questions from the group for Tracy about the case?
Did she experience any depression prior to 2017, or this was the start of it?
That was the start following her first pregnancy.
How convinced are you, Tracy, that she has bipolar depression? I mean, most of her medications are really heavy on that target, but I didn't see anything that sounded like hypomania or true mania, and wasn't sure how accurate or convinced you were that was the right diagnosis.
Well, she reported no episodes of mania or hypomania. It was just major depressive symptoms.
Okay. So do you think it's possible she has more of a unipolar type mood?
Well, I did, but I'm looking at the medications and that she didn't respond to, and I'm not really sure.
Because I mean, most of those are your heavy hitters for bipolar depression, right? I mean, and so they are not going to be as effective if it's just unipolar depression. And I mean, it other than Zoloft and Wellbutrin, that most of her, at least more recent med trials, are really heavy for bipolar depression, and it's just a different pathway. So if there's question about that, I wonder why part of it is, and the reason I bring that up is because many of those sort of AEDs, the anti-epileptics, or the antipsychotics that kind of are used for bipolar have substantial cognitive effects and dulling, and people will complain of cognitive symptoms of dulled thought, not being motivated, simply as a side effect of those classes of medication. So for me, I think going back to the drawing board and getting diagnostic accuracy about that's pretty clear, because I'm not sure if her complaints about amotivation actually are side effects of this entire class of symptoms, or if it's, you know, truly like lack of response. I don't hear ADHD screaming off the board, but I think that's where you have to really like dial back into childhood and what school experiences were like, and kind of go through, you know, early kind of symptoms, and try to dial down and separate and tease that out from the mood symptoms. But immediately I look at her meds, and I was like, if she didn't need those medicines for a true bipolar disorder diagnosis, she absolutely is sounding like she has side effects from them. So I just, that was sort of my initial impression. I don't know what other people are thinking, but those are heavy hitters with lots of cognitive symptoms, and certainly you can have people report lack of motivation just from long-term use of those, and it becomes this real like balance, you know, between side effects and like really if it's helping. Did she report any differences in those symptoms when she like stopped them? I know there are times when she stopped them. I wonder if, you know, when she stopped them, if she experienced improvement in those symptoms specifically, or maybe had a worsening of that. Because the other issue is, I mean, panic symptoms and anxiety were also highly noted in there. And, you know, panic disorder is really hard to treat without an SSRI or an alpha blocker. And so, you know, I don't know how much anxiety is playing a role in her attention issues, but I was sort of struck. I mean, those medicine combos look exactly what you would use for bipolar depression, but I wasn't convinced of that per se. So.
Okay, well, I guess that kind of is my question, because she came here with those history of, you know, Latuda and Rexulti, and really not with any benefit, and she didn't have any response to the caplyta. So that's what I was wondering, if bipolar, I guess I probably need to question to see more if it's a unipolar. She did have, I do remember us talking about mania, and she had none, but she has some major depressive episodes through the years, better and worse. And then I wondered if, I guess it's something with the postpartum, if that has anything that.
Yeah, I mean, again, it could still be unipolar depression. You know, I would look for kind of any oddities. You know, if truly people that have bipolar disorder actually even have an elevated risk postpartum, or like postpartum psychosis is more likely to be bipolar disorder. So, you know, I'd look in the context of that postpartum to see if there are any odd behaviors or severe functional impairment or other sort of signs. But, you know, sleep deprivation is pretty profound at that point too. So you get a lot of mixed symptoms. You know, Anastasia's like correct. If she really does have bipolar disorder and these medicines are helpful, exercise truly is far better than any drug to address those cognitive symptoms, because you increase frontal lobe blood flow. The movement actually helps with concentration of focus and organization as a separate pathway, and exercise has an antidepressant effect. And so lots of times people that have to be on those medicines long term, that have some of those cognitive complaints, you often can correct it just with mild exercise that's regular, because they're getting better perfusion and they report less burden, you know. So I mean, that's an excellent add-on. I mean, when you're talking about treating cognitive symptoms like of that, I mean, you're looking at dopamine and norepinephrine targets, right? Wellbutrin, stimulants, you know, but again, I think I'm just kind of worried we're layering on things, and you don't know if you're treating a side effect, you know. So if she's not reporting like great efficacy from some of those, you know, I'm not sure I'd continue them with those complaints. You know, ultimately, if you've made a really fair effort to treat it and it's not getting better, you can make a request for neuropsych or psych testing with the clear indication that she's had standard of care treatment for bipolar disorder, anxiety, and depression, and you clearly can't tell if the cognitive symptoms are secondary to side effects or an untreated attention. And you have to really demonstrate that they failed standard of care and they've been in care to get testing approved. But you could ask for that, and it could maybe separate it out a little bit. But the testing is not perfect. You're going to get, it really probably should be neuropsych too, so you can get that full cognitive picture of areas that might be dulled. But those are a little harder to articulate if you aren't sure about the diagnosis to begin with, because then you know, if you get the report back, shows cognitive symptoms, you know, are you going to be able to tell what she needs for the underlying mood stuff? So I'm sorry, I have to jump. So I love the cases. Maybe we can start with this one again next time, just to check in, because I know we didn't get enough time to probably discuss it, but I gotta jump, guys. I'm sorry.
Okay, thank you.
Any other comments from the group about the case?
My only thought was kind of what Dr. Swagger was talking about, that she doesn't seem to respond to any of the medications thus far. So maybe just, you know, a clean slate, you know, and addressing more of the depressive symptoms. But, and, you know, I agree with her that housework is overwhelming, but I don't like it either. But, you know, even simple things like starting with a list and step 1, step 2, that gives her a sense of control over it. And then she can check one thing off that she gets done. So she has a sense of mastery, a sense of success with it. So.
Yeah, I think prior to moving here, she had just went through a divorce. She came with her at her last visit, and it was difficult to get an exam in and get some questions answered. And following what was mentioned earlier about the ADD, I think I'm 90% sure during our first visit, I asked her about her childhood and those type of things, because of course in the initial you have a little more time, and she didn't have her children with her. And I don't think that there was anything really significant about her childhood with the attention. But yeah, that's kind of what I needed to question. I think I'm just maybe looking at, I'm going on the other providers' thoughts, and maybe just need to look a little differently at it. But we will start, if you want to start with this one, the next, I see her in 2 weeks. So I think I see her before the next echo. So I can kind of update everybody then.
Yeah, that would be awesome. An update would be great. And I know you have another case for next time as well. I think next time is actually the 18th. So we can do an update and then do your second case then as well. But did you have any other questions about this one for the time being? Or was everything good? You feel okay moving forward, Tracy?
Oh, yes. Thanks everyone. I do appreciate it. And yeah, I got an interesting one for the next echo also.
Yeah, no, we definitely look forward to it. Thank you so much again for presenting the case and submitting them. But yeah, if there's nothing else from the group, I know we are 2 minutes over, so I'll go into the announcements. The only announcement is that the next session will be on October 18th, and we'll be having a guest presenter, Maria Khan, presenting on OCD. So keep an eye out for that reminder. Thank you all so much. Thank you, Kelly, for the presentation, and Tracy for the case, and the rest of you for joining as well. Thank you. Have a great rest of your day, everyone. Bye.